Today we have the pleasure of hosting Dr. Sally Wenzel from the University of Pittsburgh Medical Center here for a talk on asthma phenotypes and treatments. Dr. Wenzel is a professor of medicine at the University of Pittsburgh and is the director of the University of Pittsburgh's Asthma Institute. She received her medical degree from the University of Florida, after which she completed her residency in internal medicine at Wake Forest University. She pursued a fellowship in critical care medicine and pulmonary medicine at the Medical College of Virginia, and then spent nearly 20 years at the National Jewish Medical and Research Center before joining the UPMC faculty. Dr. Wenzel has a long history of interest in asthma, severe asthma, and their phenotypes, and has written review articles in both The Lancet and Nature Medicine on this topic. She was instrumental in identifying the specific issues of severe asthma and was part of the original Severe Asthma Research Program. She was the architect and first author of the Phase 2A and 2B studies of the role of IL-4 receptor antibodies in patients with moderate to severe asthma, the results of which have been published in the New England Journal of Medicine and in The Lancet. She has also published numerous papers studying primary human airway epithelial cells in those patients with severe asthma versus those with healthy airways. Dr. Wenzel has also served as a mentor to many physician scientists over her career and received the ATS Elizabeth Rich Award for her mentoring and promotion of women in pulmonary medicine and in research. Please join me in welcoming Dr. Wenzel.
Thank you, Megan, for that very nice introduction. At some level, now that you all are sort of connected with National Jewish in Denver, I sort of feel like I'm coming home. Anyway, so it certainly is a pleasure to be here. It's a pleasure to be here to talk about a topic that has been of interest to me for a very long time. I'll just let you look at these. I don't really think they're going to influence what I say. I will say for the Phase 2A and Phase 2B data, which I will show you regarding dupilumab, despite the fact that I am the first author on both of the papers, I received absolutely no consulting fees from Sanofi or Regeneron during that period of time. All right, well, it's important, I think, that we sort of step back a little bit and put severe asthma in perspective. So about 5 to 10% of the US population has a diagnosis of asthma. Of those, about 5 to 15% have a diagnosis of difficult asthma. And I think although considerable progress has been made in understanding asthma, and even in severe asthma, many patients really remain poorly treated and subject to the side effects of the treatments. I think it's also important to point out that I think the burden of severe asthma is likely to be underestimated. So this was a very interesting study that was put on by a consortium of pharmaceutical companies called the Asthma Insight and Management study. And I think this is very interesting. This was a survey of patients, actually, asking them about the frequency of taking oral steroids for asthma symptoms in the last 12 months. This was a sample of about 1,000 patients. And they asked them, how often have you taken oral steroids over the last 12 months? And you can see it ranges anywhere from from once to more than 10 times. But interestingly, this is wrong here, it's actually 33% of the asthma population that says they've taken oral steroids 4 or more times in the previous year. Now, I can tell you as a physician in a severe asthma clinic, I actually do see that very frequently in patients that are referred to me. Oh, you know, I go on prednisone burst every month or two. Like, really? Because I think that's not a goal of treatment, is to get a patient to being on an oral steroid burst once every month or two. So there is a need to understand and treat this disease better. But I think before we can really focus on that, it's important to define severe asthma. I've been part of the ERS and the ATS workshop and guidelines on severe asthma and difficult asthma. I was part of the initial definition back in 2000 that was done by the ATS, and then more recently merged with the ERS and published in the European Respiratory Journal in 2014. And we actually thought that it was probably a 3-step process. Before you could really identify a patient as having severe asthma, you needed to confirm an asthma diagnosis and identify difficult to treat asthma. You needed to be able to differentiate severe asthma from milder asthma. And then finally, it was important to determine whether the severe asthma is controlled or uncontrolled. So it's pretty straightforward, but despite that, I think there are certain points that need to be made. So the first part, confirm an asthma diagnosis and identify the patient as having difficult to treat asthma. This is probably the most critical element of the definition. It requires that other primary diagnoses be excluded, including vocal cord dysfunction. It requires appropriate treatment of comorbidities, including poor adherence, addressable environmental exposures, et cetera. And at least according to the ERS-ATS guidelines, we recommend that there is an evaluation and treatment by an asthma specialist for 3 or more months, because believe it or not, once you get to difficult or more severe asthma, it's actually a pretty complicated disease with lots of nuances. So the first part, to make sure the patient has asthma. I think despite the fact that we all consider asthma kind of a simple disease, it's really not so simple a disease. And I actually had seen my first 150 patients when I moved from National Jewish to the University of Pittsburgh, and actually had cataloged them, and went back after seeing those first 150 patients, and actually tried to identify, of the patients that were referred to me for a diagnosis of difficult asthma, how many of those actually had asthma in the end. And as it turned out, about 2/3 had a diagnosis of asthma, but nearly 1/3 of patients had no diagnosis of asthma, despite the fact that they were referred to me as a specialist in a specialty clinic for a evaluation and treatment of difficult asthma. Now, this is very similar to results that were published in 2008 in Canada in a random dialing approach where they evaluated 500 asthmatics and again found that about 1/3 of the patients didn't have asthma. And then even recently an even larger study from the same group published in January of this year showed that about 1/3 of patients with a diagnosis of asthma do not in fact have asthma. Now that's a huge problem because there's, again, 1/3 of patients out there running around being treated, often in to a high degree, for a diagnosis of asthma when they actually don't have asthma, despite the fact that we all think of this as a pretty common, easy to treat disease. So what's important in that understanding of whether the patient really has asthma or not? It's spirometry. Now spirometry has been around for nearly 100 years. It is a very simple, very accurate, very well-defined test that in that study by Aaron et al. Actually looked like about 50% of the patients who had that diagnosis of asthma that was incorrect had never had. So that's a huge thing that we can all contribute to by just getting spirometry on our patients. Now, granted, when a patient has no symptoms, their spirometry may be normal. But in fact, when a patient has symptoms, their spirometry should not be normal. So just as a reminder, it's a very relatively simple test. There are really 3 measures that need to be addressed. The first is the forced expiratory volume in 1 second, how much a patient can exhale forcibly in 1 second, compared to the forced vital capacity, that entire amount of air that they can get out in a full expiratory maneuver, and then the ratio of that, so how the expiratory volume in 1 second compares to the forced vital capacity, the full volume. And you want to see that that is reduced in someone with obstructive airway disease. And of course, there's some nuances there for age, et cetera. The older the patient is, the lower that ratio may be normally. But if you've got a young person with a ratio actually less than 75% predicted, that's a pretty good indication that there is, in fact, some airway obstruction. Now, of course, when you're looking at asthma, you actually want to make sure that you have an improvement in that lung function testing after a bronchodilator. That is truly the definition of asthma, is a 12% improvement in FEV1 or greater than 200 milliliter improvement in FEV1 post-bronchodilator. And if you don't see that improvement post-bronchodilator, then you have to question whether the patient does, in fact, have asthma. It's also important to be able to actually obtain a flow volume loop. So not just the numbers, it's actually really important to look at the flow volume loop as well, and I'm going to go over that in a little bit when I talk more about vocal cord dysfunction. But everything below the line here, below the x-axis, is inspiration. Everything above the line is expiration. And again, I think it's very important to compare the upper and the lower portions of that graph. So when do you start to worry about masqueraders? When do you start to worry that maybe this isn't asthma? Well, as I already kind of alluded to, when someone has normal spirometry, but their symptoms are out of proportion to their relatively normal FEV1, or they lack a bronchodilator response, those are very important people to look at a little bit more closely. Abnormal spirometry, but there's an atypical pattern to the symptoms. Maybe they're just short of breath all the time and they don't really have exacerbations. Those are patients who you want to consider, as well as those patients who just have a poor response to medications. Well, certainly in our studies, and I think if you look through that JAMA paper a little bit more closely, probably the most common masquerader is vocal cord dysfunction. So what is vocal cord dysfunction? Vocal cord dysfunction is paradoxical inspiratory closure of the vocal cords. It can be induced or spontaneous. It is diagnosed by history, by flow volume loops, and definitively by laryngoscopy, and the patients may in fact have concurrent asthma. This is again that flow volume loop that I showed you previously. This is expiration, this is inspiration, this is a normal flow volume loop. What happens with vocal cord dysfunction, a disease of inspiration, obstruction during inspiration, is that inspiratory part of the flow volume loop is in fact flattened or truncated. And there's all sorts of varieties of forms that this can take on inspiration, but generally speaking, you see it just being flattened across the inspiratory, across the x-axis. And that's because the patient starts to take a breath in, and then it kind of the vocal cords sort of close, and the flow is much lower than it is normally, where you get a nice increase in a maximum inspiratory flow before the flow returns to zero. So very truncated inspiratory flow. But then you look at expiration. Asthma is a disease of expiration. You see that it's completely normal. No difference from the normal flow volume curve. So clearly can be diagnosed or at least potentially recognized on just a simple test like a flow volume curve from spirometry. And then, of course, to definitively diagnose it, you're going to want to look at the vocal cords. These are, I think, very nice representative figures. So normally during inspiration, the vocal cords are completely open. This is a patient with very extreme vocal cord dysfunction who, on inspiration, those vocal cords are almost completely closed. And you can, again, see everything in between this completely open to completely closed. But believe it or not, that patient's still getting a little bit of air through that slit. So they're able to stay alive, but clearly they're going to be symptomatic. So when you see someone with vocal cord dysfunction, what are sort of the red flags that you should make you think that this is someone who I'm going to consider vocal cord dysfunction in? Often these patients have a long history of asthma exacerbations, often with multiple visits to the emergency room and or hospitalizations. And of course, if New York is anything like Pittsburgh, I can't get physicians in the emergency room to ever do spirometry on a patient in the emergency room. So clearly they're all treated as asthma. They all get beta agonists. They almost always get some steroids without a real good diagnostic evaluation. These patients are on high doses of nearly every asthma medication, including systemic corticosteroids, and they'll tell you, if you ask them, gee, which of these medications seem to help you the most, they'll often say, well, none of these medications help me, but doctors keep giving me more and more of these medications because I'm not getting better. So these are patients who often will present with episodic cough, shortness of breath. The very common story is that they will be walking down the perfume aisle at Macy's and they can't breathe anymore because their vocal cords close, and they will tell you, I'm just allergic to perfumes. Well, they're not really allergic to perfumes because you're not allergic to perfumes. You have a sensitivity to perfumes, but that's a very, very common presentation. They will also tell you that they can't get enough air. They can't get it in. And if you ask them specifically, is it harder to get the air in or harder to get the air out, they will almost always say, I just can't get my air in, which is not surprising since they're having closure of the vocal cords during inspiration. It's typically associated with gastroesophageal reflux disease, postnasal drip, and anxiety. And I think this vocal cord dysfunction was originally described in women, often with a history of sexual abuse. But I think we know now it's way more common than that. And if you treat these three elements, you can often improve the symptoms. And of course, symptoms will persist despite normal pulmonary function testing. So what about patients with abnormal spirometry? So these are patients who often have an obstructive pattern to their spirometry. Again, probably the most common one is a COPD, and of course now people want to talk about asthma-COPD overlap syndrome, where patients have a history of asthma and maybe they smoke. I think it's all part of a spectrum, to be quite honest with you. But if there's a history of smoking, even in a young person, I think you have to consider that it may not be asthma, but it might be COPD. Allergic bronchopulmonary aspergillosis, very uncommon, but certainly should be considered in the diagnosis, as well as constrictive bronchiolitis. And if you've got someone who has a history of exposure to various toxins, smokes, et cetera, that's something that should be on your list. A restrictive pattern, you know, you're probably not going to have a problem differentiating interstitial pulmonary fibrosis from asthma. And a restrictive pattern would be seen in someone who has a fibrotic problem. But you can see a restrictive pattern in patients who are also obese. So these are patients who have a low FEV1, but a low forced vital capacity as well, so that their ratio is not reduced. And believe it or not, obesity has been misdiagnosed as asthma on numerous occasions because of the shortness of breath that occurs. So if you see a young person who's obese who comes to you with a diagnosis of asthma, again, be a little suspicious that it might not be asthma, it may just be obesity. You can have a mixed pattern where you have a low FEV1 and an FVC, but the ratio is still low, often maybe not with as much of a bronchodilator response as you would expect. Hypersensitivity pneumonitis is probably the biggest one on the list here. I'd even add to that immunodeficiency syndromes. I actually see a lot of immunodeficiency syndromes these days that are also sort of masquerading as asthma. Sjögren's, eosinophilic granulomatosis, and polyangiitis. Again, very rare. And I'm going to spend a little bit of time talking about asthmatic granulomatosis or autoimmune airway disease, which I think is much more common than Sjögren's EGPA. And of course, the diagnosis is often helped by more advanced lung testing, CT scans, diffusing capacities, those sorts of things. All right, so we've made our diagnosis. We actually do think it's severe asthma now, and we want to differentiate from milder asthma. So severe asthma, the diagnosis of severe asthma requires that the patient requires treatment with high doses of inhaled corticosteroids, 1,000 micrograms of fluticasone or equivalent, plus a second controller and or systemic corticosteroids to prevent it from being uncontrolled or which remains uncontrolled despite that therapy. So obviously we want to try to get the patient better. And if it's just difficult asthma, you should actually be able to get the patient better. And so there are things that we need to consider, including reversible associated factors like smoking. And of course, the statistics are that 20 to 25% of the asthmatic population actually smokes. Well, that's actually, if you believe that statistics, it's higher than the general population, which I'm not quite sure I fully believe. But certainly if a patient is smoking, that is certainly something to address. It's certainly also likely that if they are smoking, they have a different type of disease that may be less responsive to inhaled corticosteroids. And again, it may be on that spectrum along the line going to a COPD sort of picture as opposed to a true asthma picture. Obviously, you can have patients that have persistent allergen exposure. For whatever reason, they know they're allergic to cats, but they choose to have a cat in the house and they choose to sleep with the cat, et cetera. Obviously, that's something that needs to be addressed. Although, interestingly, most of the data looking at patients with more severe disease, with truly severe disease, suggests that they are less allergic than milder patients with asthma. So to focus only on allergen exposure is probably not correct as well. And then, of course, anxiety can make their symptoms a lot worse, and they may actually not have that severe and underlying disease. And then the big one, compliance and adherence. So patients not using their medications appropriately or correctly has long been associated with severe asthma. And severe asthma, actually, when I was growing up at National Jewish, was almost always labeled as a disease of noncompliance or adherence. If you could just get patients to take their medicines, they'd be better. Well, in many cases, that is correct. But the reasons for compliance, for poor compliance, are varied, complex, and really appropriate to go into in detail. So when I look at my list, I can start with patients don't like taking inhaled medicines. There are some patients who, for whatever reasons, just taking inhaler seems to bother them. I don't think that's very common, but certainly there are some patients in that category. Medicines can be very expensive. So at this time in this talk, I always stop and I always ask, gee, if you have to go out and buy an Advair 550, now we're now at the Brio and all this other kind of stuff, but Advair 550, and you don't have insurance, how much does it cost per month? $350, $200? Somewhere between $350 and $400 a month. Now, there aren't many patients that are going to be able to go out and afford $350 to $400 a month if they don't have insurance. And goodness knows what direction we're going to be headed in over the next several years. But I would argue that if a patient's got kids to feed and asthma, and they have the choice between buying their Advair inhaler and taking it every month, they're probably going to feed their kids. So I think that's an incredibly important issue to address and to try to help with, but there aren't that many resources for patients from the standpoint of the cost of medications. Then you've got young people. Young people don't want to be dependent on a medication because it's a sign of weakness. Oh, I don't have to take a medicine every day. I'm healthy enough. I don't need to take a medicine every day. It's admitting that they have poor health. And then finally, obviously, they forgot. I always like to use my example of when I have to take an antibiotic twice a day for 10 days. Oh, I'm really good for the first 5 or 6 days. And then I get to the 7th day, and I'll take it in the morning, and I forget the evening dose. By the time I'm at the 10th day, I'm hardly remembering to take it at all. I'm a doctor. I know all the risks of not finishing a course of antibiotics, et cetera, and I still struggle. So it's a human condition. And in fact, when they've done studies now of oral cancer chemotherapy patients, this is take your drugs or you'll die. They found that the compliance and adherence rates for oral cancer chemotherapy drugs is almost exactly what it is for asthma. It's about 50%. So it's not specific to asthma. And for us to sort of single out asthma and say it's just because you're not taking your medicines is, I think, not stepping back and sort of realizing what the human condition is. And then from the standpoint of severe asthma, what if the medicines don't work? And your doctor's telling you every day you should take this medicine. You don't feel any better. You've taken it for 2 weeks. Nothing happens. Why would you continue to take that medicine? So again, there are multiple elements in here that I think are important to go through. And then, of course, you've got patients who do take their inhaled medications, but no one ever spent the time telling them how to take them. And there's a big difference in how you take a medicine as opposed to how it will work. And of course, now in asthma, we've got many different devices to actually deal with, and each of them requires a slightly different approach to their use. Of course, you've got also then patients who have comorbidities that worsen asthma. The asthma may not be severe, but the complexity of the presentation makes it appear severe. Obesity profoundly worsens shortness of breath, but again, may not be due to an obstructive physiology or bronchial hyperresponsiveness. Asthma is more likely to be misdiagnosed in obese men, especially if they have an urgent healthcare utilization. Patients with chronic sinusitis worsens the cough, worsens the sputum. very difficult to treat. We don't have good answers there. And then gastroesophageal reflux, clearly associated with asthma, but little evidence for any cause and effect. And I think it's much more likely that this gastroesophageal reflux is associated with upper airway problems, vocal cord dysfunction, than it is with asthma per se. Okay. So now we know that the patient really has severe asthma. We've checked the boxes on all these things that might be making it look more severe. Now we want to determine whether it's uncontrolled or controlled. And this is where I think we've set up fairly specific criteria based on poor symptom control, frequent severe exacerbations, a serious exacerbation, or airflow limitation. And if a patient has any one of these four, it qualifies them as being uncontrolled. I think we like to use, for poor symptom control, we like to use standardized questionnaires because, again, it's very easy to actually come up with a criteria for whether you meet levels of control or not. The asthma control questionnaire or the asthma control test, each of which have guidelines for not well controlled as well as NAAPP or GINA guidelines. I think it can be very helpful in that regard. And then obviously having 2 or more bursts of oral corticosteroids is considered poor control, having a hospitalization or ICU visit, and then evidence for airflow limitation following a medication withhold. Any of those actually get you into the category of uncontrolled disease. Well, I think you can probably see from that initial presentation that basically our definition of severe asthma in 2017 or 2014 when it was actually written is pretty nonspecific. You can get there in a variety of different ways. So I like to consider it pretty much of an umbrella term. And under that umbrella, there are different factors that contribute to making you severe. So symptoms, exacerbations, lung function, all of those contribute to making you severe. But it doesn't tell us anything about the underlying disease that the patient may have. And depending upon that mix, you actually can have quite a different disease presentation. So I like to support or suggest that asthma is really one of the 3 A's. And the 3 A's that I can easily think of are arthritis, anemia, and asthma. Now, how are they all like? Well, obviously, they all start with an A. But that's not really the point of why I'm bringing this up. They are all nonspecific general characteristics of disease. They describe joint swelling, low red blood cell numbers, reversible airway obstruction. And if you think about those terms, they shed nothing, no light whatsoever on what's happening underneath. So you can have someone present with a low hemoglobin, but you don't know whether it's due to iron deficiency, B12 deficiency, folate deficiency, they're bleeding out, etc. All you know is you've got a marker that they have anemia. And certainly, likewise, no self-respecting rheumatologist would ever diagnose a patient with arthritis. So we're not quite to that specific B12 deficiency anemia yet in asthma, but we're getting closer. And I think we all realize that that umbrella term of asthma contains multiple phenotypes. So a phenotype is a grouping of characteristics that are generally caused by a combination of the genetics of the patient in combination with the exposure to the environment. And I think we've taken a lot of steps in the asthma arena to try to identify phenotypes. Now, this was a paper now 7 years old from the Severe Asthma Research Program, which was purely based on clinical phenotyping, actually looking at about 780 patients in the Severe Asthma Research Program, doing a clustering analysis based primarily on clinical factors and showing that age at onset and lung function were very important to identifying which cluster of patients you actually fell into. We had 3 clusters of early onset patients, most of whom were allergic when you looked at skin testing responses and IgE, and then a couple of clusters of later onset patients, one of whom was actually very non-allergic, primarily female, and then a final cluster of very severe patients, again, primarily later onset disease with the worst disease. And although this was very helpful, it didn't tell us anything about the underlying molecular patterns to these different phenotypes. And so we're actually hoping now that we can move from this clinical phenotyping, which is, again, overlapping clinical, physiologic, hereditary characteristics, to moving towards inflammatory and molecular phenotypes. And this is, of course, the incorporation of associated pathobiologic mechanisms, ideally at a molecular level, to define a clinically recognizable phenotype and to target it for treatment. So a big step in this direction was taken by, I think, this very important paper published in 2009 from the University of California, San Francisco, where they had actually done bronchoscopies on patients with asthma. And they had brushed out epithelial cells, and they had looked at what they make. Now, previous studies had shown that if you stimulate those same epithelial cells in a little cell culture dish with IL-13, that they could make all these different things, but 3 of which were periostin, CLICA-A1, and serpin-B2. So signature genes is what they've been called when you stimulate the cells with IL-13. But they went back to their fresh epithelial cells that they had gotten from the airways of the asthmatics and looked for the expression of those 3 genes. 3 genes that were stimulated by IL-13, the type 2 Th2 cytokine. And they found, perhaps much to their surprise, that about 50% of the asthmatics had very high levels, so orange is high levels of those genes in their airway epithelial cells. But the other 50% were really mixed in here with the healthy controls and no different from the healthy controls. But if they looked at the characteristics of the patients over here in the orange with high levels, they found that those patients were more likely to be atopic and allergic, have eosinophils in their tissue, evidence of airway remodeling, bronchial hyperresponsiveness, and increased type 2 cytokines in their tissue, so IL-4, IL-5, IL-13. So seemed to fit a pattern that there was, in fact, a molecular phenotype that associated with that pattern of inflammation. But probably the most important thing that they did was they actually had treated these patients with inhaled corticosteroids. These were all patients who were not inhaled corticosteroids coming in. And they looked at their response, their clinical response to the inhaled corticosteroids. And what they found was those patients that were in the Th2 type 2 high group had a big improvement in FEV1. They got better with treatment with inhaled steroids. But if you were in that low group, nothing happened to you. You didn't get better at all. Hence my referral to, oh, maybe the drugs don't work. But clearly, you can see that if you were in that type 2 high group. So it identified a very recognizable inflammatory phenotype that responded to inhaled corticosteroids. Now, this has been applied to other inflammatory biomarkers as well. This was a study from the Asthma Clinical Research Network, another NHLBI-sponsored network, where they looked retrospectively at all the patients in the various clinical trials based on their sputum eosinophil count. So they looked at eosinophils in the sputum. And they had patients that had been evaluated by sputum eosinophils on at least 3 different occasions. And they divided those patients into those that had no eosinophils ever, those that had intermittent eosinophils, 1 of 3 times, and those that had persistent eosinophils in their sputum. So not quite as accessible as blood, but certainly something that was done as part of this network. And I think you can see this is, again, this is their improvement in FEV1 in response to inhaled corticosteroids and then in response to a bronchodilator like albuterol. And I think you can see that if you have eosinophils in your sputum, you get a nice improvement in your lung function in response to inhaled corticosteroids. You get a bronchodilator, you get even better. But if you have no eosinophils in this flat line here, you don't respond to inhaled corticosteroids at all, but you do still respond to a bronchodilator. So you meet the criteria for asthma, but you don't respond to inhaled corticosteroids. If you have intermittent eosinophils in your sputum, you respond a little bit, but not as much as the patients that have persistent eosinophils. And again, after the bronchodilator, everyone gets better. So very different clinical responses to our gold standard treatment for asthma. Now, I think this has caused many of us to sort of step back a little bit and say, okay, well, maybe we need to start dividing asthma into those patients that have some evidence of type 2 or Th2 inflammation versus those that have no or less evidence for type 2 inflammation. And when we treat patients, it's important to understand which category they actually fall into. Now, certainly, we've had a lot of interest in this whole Th2 type 2 pathway in relationship to asthma. It's been incredibly well worked out in mouse models, et cetera. But I think this concept that maybe there's a difference in how we treat patients based on whether they have type 2 inflammation really has led to the development and the search and development for molecular targets or biomarkers to help us identify these patients. And of course, when we talk about Th2 or type 2 cytokines, we're talking about IL-4, IL-13, IL-5, IL-4 and IL-13. IL-5 are typically made by Th2 cells, but there are other cells that may produce these cytokines as well. But I think it's important to note that these cytokines have an impact on other parameters that we can now begin to address. And probably blood eosinophils have gotten the most press recently. Blood eosinophils identify patients who most likely have an increase in IL-5, the Th2 cytokine IL-5. We can all measure them. We can measure them very easily on a CBC. Periostin is made when the IL-4 and IL-13 stimulates the airway epithelium. You saw that. You can measure it in the bronchoscopy samples, but you can also measure that in the blood. And then finally, inducible nitric oxide synthase, which is also stimulated in the airway epithelium by IL-4 and IL-13, makes a biomarker called nitric oxide. You can measure that in the breath in patients that have a diagnosis of asthma to see whether it's high or low. And again, there are various parameters that have been identified to determine whether it's in fact high or low. So I think the next step in determining whether these type 2 biomarkers really are identifying patients who have a type 2 associated disease that responds in a molecular pattern to specific targeted therapy is to target those patients with a specific biologic that impacts a specific arm of the pathway. And this is where I was, again, very fortunate to be involved early on with a drug called dupilumab, which actually will probably be approved for treatment of atopic dermatitis this spring. So this drug is going to be very close to the market. This drug blocks both IL-4 and IL-13 through the IL-4 receptor. The IL-4 receptor can be combined in a heterodimer with a common gamma chain, which is the type 1 receptor, which is present primarily on inflammatory cells, also maybe on fibroblasts, as well as being combined with the IL-13 receptor alpha, the type 2 receptor, which is very commonly seen on a variety of different cell types. So this drug, this monoclonal antibody, was targeted to patients with high levels of blood eosinophils. So again, that very easy to obtain biomarker for a type 2 inflammatory process. And this initial study was done in patients with moderate to severe disease who were actually reasonably well controlled at baseline. They were all put on a similar background medication, and then we started treating them with dupilumab or placebo. For 4 weeks, their background medications were held completely stable. And then after 4 weeks, you started tapering off their background medication. So starting with the long-acting beta agonist, that went away, and then successive reductions in their inhaled corticosteroids, such that the last 3 weeks, they were only on the medication that they were on, either placebo or dupilumab. Now, the primary outcome for this somewhat contrived study was loss of asthma control when you took off their background medication. And I think the results were really quite striking. So if you were on placebo, everyone was relatively stable for this background stable phase. But then as you tapered off the background medication on placebo, you can see that nearly 50% of the patients actually had a loss of asthma control in that arm. But if you were on dupilumab, there were only 2 patients that had a loss of asthma control. This was an 87% reduction in loss of asthma control. And remember, the last 3 weeks, the patients were on no background medications. They were either on placebo or drug, and that was it. Now, in addition to preventing this loss of asthma control, there actually was an improvement in lung function. And you have to remember, this is on top of combination therapy. So this is on top of long-acting beta agonist and inhaled corticosteroid. And despite that, there was still about a 250 milliliter improvement in FEV1 on top of combination therapy. And then you started tapering off the background medication. The placebo group generally fell, and of course there are dropouts here as the patients lost control, but they were clearly less at the end of the study than they were at the beginning. But you can see that the dupilumab arm had about a small reduction in their FEV1 when you discontinued the long-acting beta agonist, but then they were actually relatively stable despite the withdrawal of the background medication. And in fact, at the end of the trial, they were actually still higher than they were at the beginning of the trial when they were on combination therapy. So really pretty striking improvements. Now, again, in order to really show that this is due to blocking that IL-4 receptor pathway, you want to have a biologic biomarker that's actually improving as you treat these patients. And I mentioned exhaled nitric oxide. Exhaled nitric oxide can be measured in the breath. We know that exhaled nitric oxide is induced by IL-4 and IL-13. So not too surprising that when you treated with dupilumab, there was about a 40% reduction in exhaled nitric oxide, proving the biology of that pathway had in fact been impacted by treatment with dupilumab. And of course, as you would hope, on the placebo arm, as you started tapering off the medication, you can see there was a rise in the exhaled nitric oxide. So not only did dupilumab improve the exhaled nitric oxide when you tapered off inhaled corticosteroids, the exhaled nitric oxide went up. And what was very nice to see was that the improvement in lung function, the improvement in FEV1, correlated with the fall in exhaled nitric oxide. Really, I think, suggesting that the changes, the improvements that we were seeing were based on the biology of the pathway. Now that was the phase 2A study. The phase 2A study was in 100 patients. It was a small study, et cetera. So it was really important to take this drug into phase 2. Into phase 2, it was studied in a broader population of patients, which I'll come back to towards the end. But certainly one of the subgroups was the patients who had blood eosinophils greater than 300. 300 is a very easy threshold to get to. If you look through electronic medical records, you'll find many, if not most, of your asthma patients will have blood eosinophils of 300 or above. And in that population of patients, over this is the primary outcome was at 12 weeks, you can see that there was a very nice improvement in FEV1 in this more real-world study on top of combination therapy as compared to placebo. So the findings held up. But in that study, we now started looking at real-world exacerbations of asthma that require prednisone or ER visits or hospitalizations. And if you look in the patients, again, who have this type 2 biomarker of eosinophils, there was, again, a very profound reduction, about an 80% reduction in exacerbations in the patients with high levels of eosinophils who were treated with the every 2-week doses. This has the every 4-week doses. These are not going to move forward into the phase 3 studies, but the phase 3 studies will only look at Q2-week dosing, and again, you can see a very dramatic reduction of around 70 to 80% in the patients that were getting the drug every 2 weeks. So I think pretty clear indication that there's at least a subgroup of asthma where this type 2 pathway is really important. It's a molecular phenotype that's guided by that. Now, as a clinician who sees these patients all the time, I have to wonder, are these type 2 patients all the same disease? And I guess one of the things that makes me think that they're not is that difference by age at onset. So there's a very different phenotype that we see in the clinic in someone who's had asthma their whole life versus asthma who's gotten it in adulthood. And one of the prime differentiating features that we see is that actually eosinophils, blood eosinophils, sputum eosinophils, lung eosinophils, are more common in patients who got their disease in adulthood versus getting it in childhood. This is from a study we did years ago where we actually showed eosinophils increased in the tissue in patients with adult onset disease versus childhood onset disease. This is a study from the UK identifying a group of patients with late onset, very highly eosinophilic disease. All these patients with late onset disease are generally less likely to be atopic. They often have nasal polyps, chronic sinusitis, aspirin sensitivity, so very distinct from the childhood onset patients. Well, why do we care about these eosinophils so much? We care because there's been increasing evidence that the higher levels you have of these eosinophils, this is in your blood, the more likely you are to have an asthma exacerbation, to have more difficult to control disease. This is looking at, again, a breakdown of eosinophils starting at 200 to 300 and going all the way up to 1,000 cells per microliter in a huge United Kingdom database, and I think showing you a pretty nice dose response in that the higher your eosinophils in your blood, the more likely you are to have an exacerbation of your asthma in the previous year. So important to look at. Now, eosinophils themselves have been a target for treatment of asthma for a very long time. And IL-5, interleukin-5, as I showed you on that previous diagram, is probably the most potent cytokine to induce eosinophilia. Interestingly, it was studied years ago, 18 years ago, and in patients with all asthma. And when you took patients with all asthma, anti-IL-5 didn't work at all. But fortunately, some of our colleagues in the UK said, well, that's kind of crazy. You should target anti-IL-5 into a group of patients that actually have eosinophils. And so this was the first study that was actually published with anti-IL-5 in the New England Journal now many years ago, where they targeted patients who had eosinophilic asthma with an anti-IL-5 approach. And many of these patients had late onset nasal polyposis, sinusitis-associated disease. And when they targeted this drug to eosinophilic patients, there was about a 40% reduction in asthma exacerbations. Now, that was really the tip of the iceberg. There have been multiple studies that have been reported since then, and we actually now have 2 anti-IL-5 antibodies approved by the FDA for use in the United States for eosinophilic asthma as measured in the blood. You don't have to measure sputum, you just have to measure blood, and the primary efficacy is about a 40 to 50% reduction in asthma exacerbations. And so very consistent, and I think one of the important outshoots of this was actually a study in patients with the most severe asthma. These were patients who were on oral steroids every day. And they actually looked at them in probably the best published study to date, where they optimized their oral steroid dose. They then added on anti-IL-5 or placebo on top of their background medication and then reduced their oral corticosteroids and compared mepolizumab, one of the anti-IL-5s, to placebo. And I think what they showed very, very nicely and strikingly was that there were 40% or so of the severe asthmatics that were treated with mepolizumab that were able to have a 75% or greater reduction in their oral steroid dose compared to 18% on placebo. This was very statistically significant. But I think it's also important to point out that even in a group that was targeted specifically because of their high blood eosinophils for treatment with anti-IL-5, there was still 30 to 40% with no or minimal reduction despite this starting eosinophilia. So why is that? Well, I think we're now sort of moving in probably the most complex group of patients. These are patients who, again, I've been seeing in my clinic for a very long period of time because I specialize in these patients. I have some patients from New York, as well as the whole northeast part of the country. But the first patients that we identified were 10 severe asthma patients. I'm now up to probably 35 or 40, actually, who met an asthma diagnosis, all on systemic corticosteroids of 10 milligrams or above, all of whom had very miserable quality of life, often with adult onset or adult worsening, modest obstruction on spirometry testing, often with a small decrease in forced vital capacity and a decrease in diffusing capacity. Diffusing capacity is supposed to be normal or high in patients with asthma. They almost all had high exhaled nitric oxide, often with high blood eosinophils, despite systemic corticosteroids. An autoimmune family history was seen in about 70% of these patients. And because of the severity of the disease in these patients, despite the fact that this is not commonly done, I thought it's important to understand what's going on in the lungs of these patients. And so all of these patients underwent video-assisted thoracoscopic surgical biopsies, so big chunks of tissue. And of course, what we found in about 50% of these patients now was really quite surprising to us. We found certainly very strong evidence of small airway inflammation. For those of you who don't look at a lung very often, this is a small airway, and there is massive inflammation around that airway, thickened subepithelial basement membrane, goblet cell hyperplasia, and a big old plug of mucus. You can see why that patient had some problems breathing. But perhaps what we didn't expect to find is right over here, which is a granuloma. So there shouldn't be granulomas in patients with asthma. That's never been described before. But what we found is that when you do have these granulomas present, and you'll often have lymphocytic bronchiolitis and in other airways, lymphocytic infiltrates, et cetera, that these patients actually can respond very substantially to azathioprine or other alternative immunosuppressives, and you can reduce their oral steroids when you treat this alternative type of inflammation. So I'm going to spend just the last little bit talking about type 2 low asthma. This is a group of patients who are much less well defined than type 2 high. They're defined as the apparent absence of type 2 inflammation, but really defined by our current very limited biomarkers. No definite endotypes or molecular phenotypes in this group of patients, but lots of confounders, post-infectious, obesity, smoking, long disease duration, really very non-specific sort of factors, and all have been associated with a poor corticosteroid response. So probably the best defined group of type 2 low patients are obese, late onset asthmatic patients. This was, I think, a very important study by Ann Dixon up at the University of Vermont, where she identified 23 obese asthmatics and evaluated them before and 12 months after bariatric surgery. So they lost a huge amount of weight with the bariatric surgery. She roughly divided them into type 2 high and the low, and on the basis of IgE levels, probably not the best way to do it, but that's what she had. She had a low group with a very low level of IgE, and then a high group with very high levels, and certainly the low IgE group had late onset disease. And what she showed was that if you were that late onset, low IgE, less likely to be allergic asthma group, after surgery, you had a big improvement in your methylcholine hyperresponsiveness. You got a lot less twitchy. But if you were in that group that was more typically asthmatic, allergic, high IgE levels, et cetera, there was really no improvement in methylcholine hyperresponsiveness whatsoever. Now, all patients felt better when they lost the weight, but treating the underlying abnormality, bronchial hyperresponsiveness, only was seen in patients who had that less inflamed sort of asthma. And it suggests that weight loss will really be more effective in some types of asthma patients than others. Bronchial thermoplasty. Can't give a talk on severe asthma without at least mentioning bronchial thermoplasty. This is an approach that actually uses a device to burn the airways, or at least heat the airways, to 65 degrees centigrade, requires 3 bronchoscopies. There's only really been one randomized placebo-controlled trial that's ever been published in about 200 patients, so a much smaller group of patients have been studied with this than any other treatment approach for severe asthma. Most of severe asthmatics that I see would have been excluded from the trials on the basis of FEV1. Less than 60% are predicted, or a history of sinus disease, which rules out many of the inflamed type 2 patients. What they found was there was a small improvement in asthma quality of life in patients that had been treated with thermoplasty as compared to placebo, but you can see that there was a big, robust improvement in asthma quality of life in anyone that got into the trial. There were a high number of exacerbations in the first 3 months post-procedure, and of course there are more and more reports of people that have now ended up in the ICU, people that maybe even have progressive lung function decline, et cetera. And certainly this has never been evaluated in the context of phenotypes. Now, the long-term safety of this is actually still, I think, unclear, as there's never been a good placebo-controlled long-term follow-up of these patients. This was a study that looked at the first couple of, well, the first 5 years of lung function changes post-thermoplasty, only in the patients that got thermoplasty. And you can see that in the first 2 years, there actually is a decline in FEV1, both pre and post-bronchodilator, perhaps more profound in post-bronchodilator in the thermoplasty group, from about 86% on average to about 81, 82% on average in the thermoplasty group, that then seems to stabilize. There's no statistics to go along with that, so I can't tell you whether it's statistically significant, but it certainly catches your eye. And I think because of the unknowns related to thermoplasty, our ERS-ATS task force suggested that you only use it in the setting of a registry or a clinical trial, because there's a lot that we don't know yet. Now, I also alluded to the fact that type 2 low asthma may be called type 2 low just because we don't have very good biomarkers for it. So this is going back to the phase 2b dupilumab study that the FDA mandated that they look in patients who had high eosinophils and low eosinophils. And really strikingly, again, focusing on the every 2-week dosing, because that's the dosing moving forward into phase 3, that sure, you saw the improvement in the patients with high eosinophils, but guess what? When you looked at the low eosinophil group, there was an improvement in FEV1 in the low eosinophil group as well that was dramatically greater than placebo, even though the overall improvement in either the placebo or the treatment groups was not as high. And I think that this effective response to IL-4 blockade, in the absence of our traditional type 2 biomarkers, suggests that maybe we need better biomarkers. Maybe we need to better identify patients that have this low type 2 inflammation. And if you look at exhaled nitric oxide, again, as a type 2 biomarker, I showed you in the phase 2a study that there was a nice reduction in exhaled nitric oxide following treatment with dupilumab. Again, here's the high eosinophil group, very nice reduction with the every 2-week dosing. But despite the fact that the exhaled nitric oxide levels were markedly lower in the patients that had low eosinophils, you can see that there is still a very substantial reduction in exhaled nitric oxide. So there was still residual type 2 inflammation there, and it suggests that this residual corticosteroid unresponsive inflammation is still present in a large number of, or a large percentage of patients with type 2 low asthma. So in conclusion, when you see someone with difficult asthma, I think it's really important to make sure that the patient has asthma, to treat all those underlying comorbidities and confounders, to use available biomarkers to identify the presence of a type 2 gene cytokine signature. And certainly you want to maximize corticosteroids for type 2 high, but consider alternatives, including type 2 targeted therapies, even diagnostic biopsies in patients with the most difficult disease, to better understand and treat these patients that we see fairly commonly in our practices. So thank you very much for your attention. I'm happy to take any questions.
Probably have time for a couple of questions.
First of all, thank you. You probably know that Strauss-Cherk did their work here.
Mm-hmm. I forgot. I nodded yes, but I did know that.
Those young people like myself were fortunate enough to be rubbing shoulders with them, and of course the fact that one was a woman 80 years ago to achieve international recognition is amazing in itself. Good for her. The other is a question. As you probably know, we have a serious geriatric program here at Sinai, and thus things to do with aging have a great interest for some of us.
Mm-hmm.
Could you comment on why asthma is more or less a disease of young people? I know older people get asthma, but it's atypical for most of the illnesses we deal with. And what research is being done about age and asthma?
A very, very good question, and I think one that is being studied more and more. I don't have a lot of answers for you. You know, the pediatric asthma is, I think what we're learning is very different from adult asthma. Even the asthma that persists from childhood into adulthood is probably only a portion, as certainly you know. About a third of patients are reported to continue to have asthma, persistent wheezing into adulthood. A third maybe go into remission and then come back later in life, and a third, it's just gone. And so what are the factors that control it in childhood? And I think the data now suggests that in childhood, for whatever reason, there's just a lot more inflammation present. And of course, you've got probably smaller airways, maybe airways that didn't mature and grow as well during childhood, or even during the young years, the infant years, when things may have happened. But all of the data say that those kids are, even if they have milder disease, are much more inflamed than a typical adult cohort. That's what we're finding out in the Severe Asthma Research Program. But then, interestingly, you almost get this inverse bell-shaped curve in that inflammation starts to come back later in life, probably somewhere around the late 40s, early 50s. And so now eosinophils that had been very low in much of the young adult years are now starting to come back up. Exhaled nitric oxide is starting to come back up. So there's some changes that are occurring, I think, in our immune system that are perhaps releasing some of the inflammation from the suppression that it went through in that sort of young adult period. But again, we've got a lot more work to do.
Okay, I mean, I know we're past the hour, so if you can stay, great. One more question, and otherwise everybody else can come up to the podium. Yes?
Hi, so Sally, thank you, that was wonderful. I've been really interested in your autoimmune granulomatous group because I think we're seeing them in our severe asthma program as well. I find it difficult to convince those patients to get orthoscopic biopsies. In many of those cases, do you have any yield at all bronchoscopically? I guess that's a diagnostic question. And then second, in terms of treatment, if I remember from your original publication, it was a pretty heterogeneous group in terms of eosinophilia and whatnot. Are you using anti-IL-5 therapies with any of those patients before resorting to immunosuppressants?
Yeah, no, I'm certainly using, and I almost always go with the drugs that are now approved for the treatment of asthma before I go to an immunosuppressive first. And I'm finding some responses in that population, but not as many as I would actually like. And I actually have a fair number of patients on anti-IL-5 and azathioprine, so that's not out of the question either. And they seem to, in some cases, do better with the combination. But I have to say, you either, I would say now a year into having anti-IL-5 to prescribe, I would say you, generally speaking, you respond to anti-IL-5 or you respond to Imuran as opposed to needing the combination. And then from the standpoint of bronchoscopy, very important question, one that we're actually trying to research a little bit with. I'm trying to do research bronchoscopies now on these patients before they go to a VATS to see if I can find a biomarker in the bronchoscopies that would predict what we see in the VATS. But up until this point, no, I don't have anything that I can specifically say, oh, this identifies a patient with asthmatic granulomatosis. Probably is going to be more type 1 or Th1 inflammation, but it's not like a direct line, unfortunately.
Okay, let's thank Dr. Wenzel. Anybody else?